Good morning, everyone. Thank you for being here on this very interesting grand rounds. Before I introduce the speaker, there are some housekeeping items. Please use your microphones to ask questions. We are broadcasting live to our worldwide audience via Vimeo and YouTube. The recording is live and always available for viewing. Please like, comment, subscribe, and share our YouTube channel. For our viewers, if you'd like to submit a question, text DeBakey to 37607. That is DEBAKEY to 37607. Our upcoming activities, I'd like to remind you, are multimodality imaging for clinicians on October 4 and 5, Surgical Technology and Robotics Summit October 6 through 10, Open Aortic Training October 24 through 25, and finally, Cardiovascular Nursing Conference on November 15. It gives me great pleasure to introduce our grand round speaker for today, Dr. Neil Pham. Dr. Pham is the Director of Structural Heart Program and the Schroeder Chair in Structural Valve and Innovation at St. Michael's Hospital in Toronto, Canada. He's an Associate Professor in the Division of Cardiology at the University of Toronto. Dr. Pham obtained his medical degree, internal medicine and cardiology training at the University of Toronto. He subsequently completed a clinical fellowship in interventional cardiology at St. Michael's Hospital. Dr. Pham's clinical and research interests include structural heart interventions with focus on valvular heart disease, performing multiple first-in-human innovative procedures, including the first transcatheter transfemoral tricuspid valve replacement using the Evoque device, the first Pascal transcatheter tricuspid valve repair, and the first transjugular mitral valve repair. He also received multiple teaching awards at the undergraduate and postgraduate level at the University of Toronto. Dr. Pham has published over 150 peer-reviewed articles, is faculty at leading cardiology conferences, and serves as associate editor and reviewer for several high-profile cardiology journals. Once again, welcome, Dr. Pham. Thank you so much, and we are all excited to hear your grand rounds lecture.
So it's really an honor and a privilege to be with you in Houston. I've never been to Houston before, but this is a very warm, welcoming place. I think I might want a job here. And the climate is way better than Toronto, except I guess in the summer it gets a bit hot. All right, so what I'm going to share with you is a bit of a device parade. I've really focused on innovation in the tricuspid space. So a lot of what I'm going to share with you is case-based. I'm going to show you how we try and match certain devices to a patient's particular disease state and anatomy, and we're going to learn something as we go. And hopefully we'll have lots of time for discussion. So no longer the forgotten valve. I think in the last 10 years, we've made tremendous progress in treating patients who have tricuspid regurgitation and heart failure, and I think we're actually getting closer to understanding which patients benefit. So we have very rapidly developed a toolbox for treating TR using catheters. It started with edge-to-edge repair. We're using the MitraClip off-label on the tricuspid valve 10 years ago, and then of course subsequently dedicated TriClip device was developed. When surgeons repair the tricuspid valve, they're doing annuloplasty. There are some annuloplasty devices out there such as the Cardioband, but they're not quite yet ready for prime time. There's been a flurry of interest in doing tricuspid valve replacement, and actually this is probably where most of the innovation is happening right now. And then we've got heterotopic valves and spacers as more of a palliative approach, which we'll also touch on. So, it starts with the patient, a clinical assessment. Hopefully they don't look like this when they come to your clinic, but sometimes they do with advanced, hepatorenal syndrome. And, they can really get along with diuretics for some time, and then eventually they kind of fall off the cliff and they end up in the hospital. So we are starting to understand who benefits most from a tricuspid intervention. Hopefully they've got preserved biventricular function, they don't have much pulmonary hypertension, it's functional TR. These patients can benefit, but we're often referred patients that look like the guy with ascites and child B cirrhosis. So, the more we look at this valve, the more we understand it's usually not tricuspid. It often has 5 scallops or 6 scallops. And it's very relevant for an intervention because if you're going to try to do an edge-to-edge repair, you have to choose which leaflet pairs to join together without distorting the valve. And it's actually pretty easy to do. So we've actually kind of learned by staring at this valve, it's really not often tricuspid. So these patients often have pulmonary hypertension. How do they do with intervention? If you have no pulmonary hypertension, I think that's best, but patients who have post-capillary pulmonary hypertension due to left-sided heart disease or HFpEF, patients actually do just fine with tricuspid intervention. The ones you want to avoid are those who have pre-capillary pulmonary hypertension, PVR more than 5 Wood units. These patients are at great risk of after-lobe mismatch, RV failure, and so really all these patients need to be screened with an invasive right heart cath. So what do we know about risk stratification? There's a number of scores out there. Probably the best one is called the TRI score. It's very intuitive. You look at a number of patient factors and look at the RV function, and then you stratify their risk as low, intermediate, or high. Now this score was first derived for surgical intervention on functional TR, and it's subsequently been validated for transcatheter intervention as well. So this trigestry has been a very productive group. What you see here is that patients who have a low TRI score or an intermediate TRI score actually seem to have a benefit with intervention, whether that's surgical or transcatheter, when compared to conservative therapy with diuretics alone. But the patients who have a high TRI score or very advanced patients with RV dysfunction and liver disease and kidney disease, it doesn't seem to be much of a benefit no matter what we do. And actually, if you have an unsuccessful tricuspid intervention, you do harm. So we're sort of learning a bit as we go about patient selection. So TR is classified as functional, atrial, ventricular, lead-induced, or primary. The question is, can one device treat all of these pathologies equally well? So, what was missing in this field was data, and we finally have some randomized trials in this space. So the first one was the Triluminate study, which we contributed to. This was the first RCT for functional TR. Does doing an intervention improve your outcome compared to medical therapy, which is basically diuretics? And so here what we found using the TriClip device was we could reduce TR to moderate or less, which is how we define success in the tricuspid space. But 90% got moderate, but only 50% got to mild. And in my experience treating TR for the past 10 years, if your symptoms are from TR and you reduce TR to mild or none, you feel that much better. It's really kind of a dose response. And I think that's what was seen in this trial. So the trial was overall in favor of TriClip, but this was driven mainly by improvements in quality of life. So having a TriClip improved your KCCQ score by 12 points. There was no improvement in mortality or heart failure at follow-up at 1 year. And the important thing to recognize in this trial is that at 1 year follow-up, if you still had symptoms and you came to the clinic saying, well, I want diuretics, I want to have my TriClip, you could then cross over. So about 2/3 of patients crossed over at 1 year. Now, there's an indirect signal here with the dose response. The more TR reduction you got, the better they felt with respect to quality of life, because trials like this can be criticized. There's no sham control, and so the placebo effect is something you have to consider. But we start to see improvements in heart outcomes such as heart failure hospitalization at 2 years. So despite the crossover in 2/3 of the patients, we start to see reductions in heart failure in the device arm of about 30%. There's no difference in mortality, but now we're starting to see improvements in heart failure. And certainly in our experience, the TriClip is a very useful tool in managing patients who have right heart failure despite diuretics. So what about other data? There's the TriFR study. This was investigator-initiated RCT done in France. Similar type of patient population, similar trial design. Here we have 300 patients. And in this trial, they found overall net clinical benefit, mainly driven by symptoms and quality of life, in favor of TriClip. So here, the quality of life improved here by 14 points, but there was no difference in heart outcomes such as death or heart failure. Now, the interesting thing about these two trials is what we found is that the mortality of functional TR was very low. So all of the natural history studies before said you have TR, you're going to die, but those trials maybe included patients who had biventricular dysfunction, pulmonary hypertension, ventricular functional TR rather than atrial. These two trials that we just discussed are mainly patients with HFpEF and atrial functional TR. Their ventricular function is preserved. So they're kind of I would say, healthier TR patients, and that's probably why we didn't see a difference in mortality. This is a very chronic disease. If you follow these patients for 5 years and you don't allow crossover, maybe we see a difference, but these trials won't answer that question. So what we've learned from the randomized trials is that residual TR predicts clinical outcome. If you have a failed TriClip and you leave them with TR that's severe or greater, it predicts heart failure or mortality compared to a successful TriClip. This was seen in the randomized trial. This was also seen in all the registries that have gone on over the past decade. So I would submit to you that getting them down to moderate TR isn't good enough. The only reason moderate TR was set as a definition of success is because we can't usually get them to mild with clips. And as a result of this, there's been an interest in developing other devices. So why can't we get them to mild, guaranteed with a clip? It's because of this, and we alluded to this. If you've got more than 3 leaflets, your procedural success goes way down. And so, you go into the case and there's a star-shaped valve with jets going into all commissures. You can't predict with great certainty that you're going to get them to mild. So what we learned so far from the T-TEER trials is that it is very safe. This is the main advantage. And actually, we really direct elderly patients who are frail, who've got comorbidities, towards a clip procedure because it's safe. You're not going to do any harm. They're going to go home the same day or the next day and feel better. You don't really have to worry about them. It's just the efficacy is the only trade-off here. Now, the difference between tricuspid and mitral TEER is that with mitral, you can usually get them to mild MR most of the time. It's become a very mature, predictable procedure. If you've got good imaging, good patient selection, it's quite effective, but it's not the same thing for tricuspid. So because of these anatomic limitations, you got to choose wisely. Before we had valves, and all we had was clips, we were trying to treat patients who had huge gaps in tethering and leads, and it wasn't always successful. And if you get a suboptimal result with a clip, you may take away future options, although there are some ways to get around that, which we're going to discuss. My own impression is that when you treat sicker patients who've got recurrent heart failure and they're not too far gone, you can really help them and sort of interrupt that cycle of coming in and out of the hospital. So all of us who do these procedures have experienced TEER regret. You put in 3 clips, you still have severe TR. What do you do? So usually redo TEER is not an option. People don't usually want to operate on these patients. You can do creative things such as elastic clip to cut the tissue bridge using electrosurgery and then put in a valve. You can do a palliative approach with heterotopic valves or maybe something else. So I'm going to share with you a bunch of cases that illustrate some of these concepts. So this is an elderly lady with AFib, HFpEF, mild post-capillary pulmonary hypertension, no CAD, mild RV dysfunction, mild MR. So she underwent a TriClip. We placed XTWs between the anteroseptal and posterior leaflets using a Clower technique. And initially, we felt pretty good. We got her from massive to moderate TR. We saw her 1-month follow-up. She felt well. But then at 6 months, she came back with recurrent class 3 symptoms and unfortunately had developed severe TR, mainly between the clips going into the AP commissure. There was no SLDA, but we couldn't really see very well between the clips to place more devices. So when we look at our toolbox, we don't have annuloplasty. We didn't think a redo clip was an option. Valve replacement, we didn't think cutting 2 tissue bridges and trying to put a valve in, at least at the time of this case, was feasible. And so we did a CT scan, and we decided to use a different approach. We placed a Gore cardioform septal occluder, which is designed for PFO closure, between the clips, using the clips as a dock or a landing zone. And those of you familiar with this device, it's nitinol, it's very flexible. It's got a PTFE membrane, so you basically block flow immediately, and you know the result you get, both for TR reduction and for gradient, which was our only other concern. But this actually worked remarkably well. So we got her down to mild TR. The device was very stable, and in follow-up, she did extremely well. Went back to class 1, and the TR has remained mild since that time. And the echocardiographers are wondering, well, what's the gradient? The gradient was 3. So, the tricuspid annulus in these patients is often huge, and they tolerate it very well. So we've actually now done this 6 different times with different device sizes, including the ASD devices. The biggest device we put in was a 44 millimeter device, and again, the gradient was like 3. And it seems to work. So we're starting a registry with this because failed clip is not so uncommon. So because of the limitations of TEER, there's been a lot of interest in doing transcatheter valves, and the speed of innovation in this space has actually outpaced mitral replacement. So on the top row, you can see the first generation valves, Evoque, Intrepid, CardioValve. These were all initially designed for the mitral valve, where they had variable efficacy, and they've all been adapted very quickly for the tricuspid valve. And on the second row there, you've got the second generation valves. These are all purpose designed for the tricuspid valve. And then on the bottom, we've got the heterotopic valves and spacers, which we will touch on. So the first across the post was the Evoque. This was where it all started. As I mentioned, it didn't work very well in the mitral position, and we worked with Edwards to say, well, maybe we can place it in the tricuspid. It's now available in 4 sizes. It's percutaneous transfemoral 28 French delivery system. So this randomized trial, TRISCEND 2, was one of the fastest enrolling valve trials that have ever been done. Actually enrolled faster than any of the partner trials for TAVI. And so this asked the question, does placing an Evoque to eliminate TR give you any benefit compared to diuretics? So this was randomized 2-to-1 against medical therapy. And as you can see here, in contrast to TriClip, where we had 50% of patients getting to mild, here we've got 95% of patients getting to mild or less TR, as you would expect from a valve replacement. Now, as far as heart outcomes, there was no difference in mortality at 1 year, although the curves are going the right direction in favor of the device. And similar thing was seen for heart failure. Now, the quality of life here improved by 18 points. In comparison, TriClip improved by 12. So this is the kind of quality of life improvement you get with TAVI. And certainly when we see these patients in follow-up, if they get a good result, and you see them at 1 month, they're very grateful, they feel much better, and you can often start to reduce their diuretics, which is not always the case with a TEER patient. Now, there were some downsides to Evoque. Their pacemaker rate was 25% in patients who didn't already have a previous pacemaker, and that's quite high. But on the basis of this data, the device has now been approved for use in Europe, US, and then more recently, a couple of months ago, in Canada. So, this was the first device. We're going to see a whole bunch more following. What have we learned about Evoque over the years? It's very versatile. So we've used this valve to treat SLDA. We've used this valve actually from a jugular approach as well for patients who have occluded femoral or iliac veins. It's very, very versatile. And it's also quite durable. So we've done about 80 Evoques in our center. We've never had to do a valve-in-valve. So I was quite surprised that these patients usually have a durable result. Now, they all have AFib, they all have to be anticoagulated, and we can talk a lot about valve thrombosis and bleeding. But, this patient, who was the first in human that we did in 2019, now has 6 years of follow-up, and his valve function is still pretty good. He has a mild intravalvular TR, hasn't had heart failure hospitalization. It's quite encouraging. Now, it sounds great in randomized trials, but once these devices are unleashed into the real world, then we actually see how they actually perform. And this registry data from the MAUD registry in the US was quite sobering as far as adverse events. Now, we don't know the denominator of patients treated here, but as you can see, there was a lot of AV block pacemakers. There was a number of malpositions, embolism requiring surgical conversion, some device failures, the nose cone separated, valve thrombosis. So this is the dark side of TTVR, and I think it just speaks to the need to still do very careful patient selection and be maybe a little bit more conservative. Don't push the limits so quickly once the device is approved. But this is also a wake-up call for the field that we need to make this procedure safer. So Because of these issues, there's been a number of different devices developed. There's probably now more than 10 valves that have had first-in-human experience, and some of them have already completed EFS. And I'm going to share with you some of the data for some of these newer valves. So the first one we'll talk about is the Topaz. Topaz is a very interesting percutaneous transfemoral valve. It's got a very soft outer frame, so the radial force is quite minimal. You don't have to anchor the leaflets. You don't need to see leaflet insertion into anchors. It's just small tines all the way around it. And because of that, the pacemaker rate has been quite low. This is the only TTVR that we've used that has more of a TAVI workflow. So it's mainly fluoro-guided procedure. You see we're doing an RV angiogram. All you need to do is make sure you define the tricuspid annular plane, and you have those markers in the middle of the valve. As long as they stay at the annulus, the valve seats itself because it has this hourglass shape. Echo is still important because you need to be in the center of the valve and perpendicular to the annulus in two planes, but aside from that, there's not much you have to do with the echo. And so here's the valve being deployed. As you can see, it's self-expanding. And so this procedure, once you get set up, takes about 10 minutes. The patient's very stable. While you're doing this, you just do rapid pacing around 140, and you can actually still move the valve around as you're deploying it. You can adjust the depth. So there's the valve deployed, and it's very good for abolishing TR. And because of this very soft frame, the RV function is also pretty well preserved. It doesn't paralyze the base of the annulus. So as you can see, I think the only downside of this valve is it has a very big ventricular footprint. They can sometimes have PVCs and that type of thing, but you can see there on the short axis how it flexes with the heart. So as I said earlier, a lot of these devices were designed femoral, but not all patients can be done femoral. If you have a big IVC offset, septal hugging trajectory, you can't get coaxial. You can do many of these valves from a jugular approach, and that was done here with the Topaz. It worked extremely well and just provided another option for a patient who didn't have any. So what about data? The EFS that was done in Europe, TRICURE, they enrolled 20 patients, typical female population with AFib and HFpEF. Here they had a 10% cardiovascular mortality, a couple of surgical conversions, probably reflects the learning curve, but they had 0% pacemaker, which is kind of what we expect from this device. With respect to TR reduction, excellent efficacy. So the next device to talk about is the Monarch. So the Monarch is a leaflet grasping device like Evoque, but it also has a skirt which you lay down on top of the annulus to seal PVL. And so this skirt can be retracted. You can reposition the device if you've got PVL. The other advantage of this device is you can treat annulus up to 60 millimeters. So when Evoque was first designed, they had two sizes. They had 44 and 48. And the first in-human patient got a 48. I said to Edwards right away, are you making a 52? They're like, oh no, those patients are too far gone. So they made a 52, and I said, are you making a 56? They're like, no, those patients are too far gone. I made a 56. I said, are you making a 60? So I think they're going to make a 60. Patients whose annulus is 60, they're not necessarily cirrhosis, end stage. Larger patients have larger annuli, and some patients tolerate this TR for a decade before they finally show up in your clinic and their annulus is huge. So anyway, this one goes up to 60. This is delivered by a jugular approach. The initial first-in-human experience that we were part of was quite favorable. 14 patients, there was one mortality, which is after a surgical conversion, pacemakers in 2 patients, and as far as efficacy for TR reduction, quite favorable, and now this device has moved into an EFS. So this next valve called the V-dyne is quite different than the others. This comes in from the side and goes towards the RVOT, so it doesn't matter your RV size. A lot of these elderly patients have very shallow RVs, doesn't matter as far as this device goes. It's kind of agnostic to what's going on with the leaflets. and it has 5 different sizes. So this valve is both repositionable and completely recapturable if you're not happy with the result. So the EFS studied 43 patients, and pretty favorable outcomes for an early experience, 4.7% mortality. There were 2 surgical conversions and a 14% rate of pacemaker. So I think this device will probably also go forward to a pivotal trial. So lead-induced TR is a bane for many of us. EPs put in the leads, and 5 years later, the patient has severe TR. So why does that happen? The lead can prop the valve open, it can become adherent to the leaf foots, it can perforate the leaf foot, it can cause RV dysfunction and functional TR. And by the time they're diagnosed, it may be too late to do a laser lead extraction, which may have some risk in these elderly patients, and then we're asked to see them. So here's another case, a 71-year-old guy who had an ICD lead extraction for device infection, and unfortunately they tore the valve. They gave him a very large flail, and he was treated medically for a couple of years, and then he developed severe right heart failure and congested liver ascites. He had, biventricular dysfunction, patent grafts. He was turned down for surgery and referred to our center. So this patient had a CT. His annulus was 52, and we decided to use this device, which is called the Lux valve. So the Lux valve is a very ingenious device from China. It's fairly agnostic to the leaf foot pathology, so it's very useful for treating cases like this, which have big flails, because the way this device anchors is through a septal anchor very distal in the septum. So there are a couple of leaf foot graspers that the leaf foots kind of just rest on, but it's not absolutely necessary for device stability. And this device can treat tricuspid annuli up to 70. So 70 sounds totally crazy. We've done it twice, and it seemed to go pretty well. So the other advantage of this device is the delivery system. You can rotate the valve on its axis to seat it down in the annulus. You can telescope it in and out to seal PVL. It's actually quite a slick delivery system. So this is what it looks like. As you can see, the anchor is mainly this 3-pronged fish hook, which anchors in the mid-septum. It doesn't affect the conduction system at all. So this is a jugular-based approach. This patient had another ICD lead placed for secondary prevention. The lead was actually in the way of putting the valve in, so we just gently applied some tension with a Gillis catheter. And then here the valve is being unsheathed. These are the 2 leaf foot graspers. And then afterwards, you fire the septal anchor, and there's this huge atrial skirt which seals PVL. And the patient did quite well. So he just got mild PVL, where the ICD is coursing through, but his clinical improvement was quite dramatic. So as far as data, this valve probably has done as many cases as Evoque, but most of them have been done in China. There was this CE mark study called Trinity, which was recently presented at PCR, and the results are quite favorable. So 150 patients, you can see here that 42% of them needed the large valve. So 42% of these patients got 60, 65, or 70 millimeter Lux valves, all of whom would have screen failed for Evoque. And mortality here is low, 1.3%. There's only 1 surgical conversion, and pacemakers are sitting around 12%. So I think we're starting to see some progress with the second generation devices. And as far as TR reduction, it's quite favorable. And so this device is probably going to go head-to-head against Evoque to get FDA approval. So I've shown you sort of a device to parade. What have we learned so far about TTVR? You abolish TR in almost all patients. These are fast, reproducible procedures. They're more like TAVI, less like CLIP. Overall, this is less reliant on procedural imaging, although if you have to visualize leaf foot insertion, then it becomes a bit more like CLIP. The advantage of TTVR is you can treat almost any pathology. It doesn't matter if you've got huge gaps, lead-induced TR, carcinoid, rheumatic, you can treat them. The downside to TTVR, as we've learned, is safety. So bleeding, PVL, embolism, surgical conversion. If you've got an old, frail patient, you have to think twice about doing this procedure, particularly if the sizing or the imaging is borderline. And of course, we've got the Achilles heel of pacemakers, although that's very device dependent. So far we haven't seen a huge signal with durability in our longest living TTVR patient who received the Navigate device, which is now no longer available. Actually, we have 8 years of follow-up and the valve's still working. And then of course screen failures, but I think if you've got access to multiple devices, that has gone down quite a bit. So there are a number of valves which are going to go up against Evoque. And so in the next few years, I think there's going to be a lot of new data generated, and it should be an exciting time, particularly for patients. So the last class of devices are the heterotopic valves and spacers. So this is, at least in my opinion, for palliation of advanced TR patients who screen fail for the workhorse devices that we have. It doesn't matter what the pathology is, you can treat these patients, but there are issues with stability, durability, and of course futility. So the Tric valve has been around for more than 10 years. So these are heterotopic valves placed in the vena cava to block the backflow, mainly into the gut, liver, and the kidneys, and maybe you're going to become more diuretic responsive. In this prospective trial done in Europe, there was an improvement in quality of life, which seemed pretty encouraging. And this device is now being studied here in a randomized trial. We've done a few Tric valves. We've also started to use this device from Israel. It's called the Unica. It's a giant stent graft that contains valves for IVC and SVC. It's actually quite a simple implant to do. It's very stable. There's no risk of embolization with this. And you can seal the caval junction in almost all patients because the skirt can treat an IVC up to 60 millimeters. So here's a case that we did. It's an 82-year-old lady, very, very advanced right heart failure, RV dysfunction, LV dysfunction, cirrhosis, 2 leads across her valve, huge gap, recurrent heart failure. So she's kind of in a desperate shape. But the procedure is done conscious sedation, transthoracic echo guidance, and angiography, and it takes 10 minutes, and it went quite well. So for these patients to benefit, we think you need to have a big V wave in the IVC. And so here's the RA and IVC waveforms, pre and then post Unica. So we can see when we seal off the vena cava, we ventricularized the RA waveform. You got V wave more than 50 there, but the IVC V wave pretty much goes away. And she actually had a very good clinical response. I mean, I've been a little bit skeptical of this type of approach, but in this case, we abolished the TR going down into her abdomen, and she stopped having heart failure hospitalizations. So here's another case, a 76-year-old patient, maybe even sicker than the previous one. His RV really doesn't contract, which is his main problem. And he's got this pacemaker lead with a very oblique posterior to anterior trajectory going across his tricuspid valve, which was really blocking access to place clips, and no one wanted to do lead extraction. So this patient was treated with the Cree valve device, which is a very ingenious device from Ireland. This is a coaptation device, like a spacer, but it has a valve in the center. So the native leaflets coapt against the outside of the valve, which is like a cylinder, and then the whole thing anchors with a stent up in the SVC. So here's the interprocedural imaging. We've got our MPR, and then here's what it looks like with the device across. You can actually control the depth of where you implant this, and then you deploy the SVC stent. This is what the fluoroscopy looks like. You jail all the pacemaker leads, and as far as a palliative approach, I think it's probably an option. They did a study in Poland, which had overall favorable results. There'd been some further iterations to this device. They've had issues with stent fracture and other things, but it is planned to go on to do an FDA study. So, last case, a very elderly female, 10 heart failure hospitalizations in a year, living on IV Lasix, terrible quality of life, but still very mentally sharp, asking us to, can we help her? This is the transgastric view. You can see she's got a huge coaptation gap, and TR just basically goes into all the commissures. So she wasn't a very good candidate for CLIP. We didn't think, given her frailty, that we were going to do a TTVR, and so she was treated with a spacer device. So you may not have heard of this one, but this device called the Versa sits on the floor of the right atrium, and it's got a disc in the center with open cells around it, and you can control the depth of the disc to try and restore coaptation of the native leaflets against it. So when I first saw this, I thought it was a little bit crazy, but actually it's quite an interesting device. So here's the fluoroscopy. So this is guided by echo. We're telescoping that disc, sort of ventricular atrial, to try and hit the sweet spot for TR reduction. And then once you're happy, it's got a number of small tines that anchor in the floor of the RA, remarkably stable. And it worked pretty well for TR reduction. So here you can see the leaflets coapting against the device. She had torrential TR at baseline. Hard to quantitate the TR, but we thought it was moderate. And clinically, it seemed to help her. She still remained on diuretics, but she stopped having heart failure hospitalizations, at least at short-term follow-up. And here's what the transthoracic looks like. You can see she's got severe RV dysfunction. You got the spacer, and the leaflets coapting against it. So in my mind, this is kind of something that might compete against CLIP in elderly frail patients, and it's more agnostic to what's going on with the leaflets. So if we talk about patient and device selection, I think we come to the place now where we have 2 devices available off the shelf. We have Evoque, we have TriClip, probably we'll soon have Pascal. There are a lot of patients in the middle who have heart failure, good RV function, small gaps, not a lot of tethering, no pulmonary hypertension, good imaging, who you could go either way. So the question is, which one of these approaches should you take? In our group, we tend to have the approach that if you're old and frail, you don't want to do any harm, you have excellent anatomy, you should have a TEER. And for younger patients who are still very active, where TR elimination is important, then we steer them towards a valve. Obviously, it's a bioprosthesis, it's going to fail, so you're not putting these into really young patients. And then, the TTVR patients really benefit. Those ones are large gap, tethering, lead-induced TR, which is probably a third of the patients we treat. But, they can't have more than moderate RV dysfunction. They can't have precapillary pulmonary hypertension, because you eliminate TR and the RV tanks, then you have a problem. Now, aside from one of our earliest patients that we did with Navigate, none of these patients has died from afterload mismatch and RV failure. You give them milrinone for a couple of days if they develop that syndrome. We don't give milrinone to all patients who get a valve. And the RV is usually quite resilient and recovers as long as you've done your adequate prehab prior to the procedure, and that you've done your case selection well with your right heart cath. So, there's a little bit of humor at the end. So if you're going to treat a patient, which would you choose? The one on the left, we placed 3 clips, took 3 hours, still severe TR. Or on the one on the right, where you put in a valve, takes 30 minutes, no TR, 3 cases done by 3 p.m. All right. So in summary, the current devices, they really improve quality of life, and I think they're a very useful tool in the management of right heart failure, and I think our heart failure colleagues are starting to see this. Tailored therapy based on anatomy, hemodynamics, disease stage, using a heart team approach will yield the best outcomes. I think we still have a lot to learn in this field, but we're learning. And finally, the long-term follow-up of these trials plus ongoing device development are eagerly anticipated. And with that, we'll take your questions.
Thanks very much, Neil. That was excellent overview of the landscape, the cases and the devices. Perhaps we'll start with Dr. Zaki.
Thank you very much, really. Through the force and tricuspid valve, and congratulations on all your contributions to the field. It was the forgotten valve, but let me tell you, it is the most accelerated research even compared to the mitral valve.
Mm-hmm.
Where you're going to have many options here. So the question to you is, you've given us the TTVR space many different mechanisms of addressing it. Some of the
issues of pacemakers versus positioning. Do you feel that ultimately we will have multiple choices for the interventionist to think about which one fits best in that particular anatomy, physiology, etc.? And the last question is, where does surgical repair fit?
Great questions. So it's definitely not one valve for all patients. Just like for TAVI, we probably need 3 different devices tailored to what the pathology is and the disease stage. So I think that's exactly what we're going to have, more than one. None of them are perfect yet. So I get asked this question, if you're on a desert island, which valve? I mean, they all have strengths and weaknesses. You have to tailor it to the patient. It's interesting about isolated tricuspid surgery because like it doesn't get done frequently, but in selected patients who screen fail for all these devices, we are doing more tricuspid surgery than we were before. But you know, the interesting thing is the surgeons have learned from the transcatheter experience, we need to optimize these patients, rehab them before they go to the OR. And if they can have a repair, you know, the literature suggests it's safer than a replacement. So, you know, a repair with a ring and maybe an edge to edge is being done, but for really terrible patients, they're still getting a replacement. And, you know, the surgical course can be rocky after.
Here, Neil, thanks. Fabulous talk. Great to see another Canadian down here showing off. 2 quick questions. So the Topaz valve, really interesting, you know, super, for those who went by quickly, you know, when you showed very thin frame, highly flexible, great images of the RV of it flexing away.
Yeah.
To me, it immediately looked a lot like an embolized Greenfield filter. You know, they fracture when you put them in the SVC or rather the IVC.
Yeah.
And do you think that valve is actually going to last a billion cycles a year?
Yeah, so the company's been certainly asked that exact question. They haven't seen any stent fractures. We haven't seen any, but like the longest follow-up we have on this is only maybe 2 or 3 years. It's a very interesting design. My only concern with that valve is the ventricular footprint, particularly with a larger valve. They probably need to make it a little bit shorter. But you know, and then of course, patients who've got really small RVs are not well served by that valve because of the ventricular footprint. The moderator band actually can impair the valve from expanding, so you have to look at that when you're doing the echo and the CT screening. But as far as a workflow and a procedural reproducibility, I think because it's simple, it's probably got some legs to it.
And this second quick question, you've done 80 or so Evoques. Can you just comment on your sort of approach to the screening for heart block and how you manage that? Because it's obviously a concern.
So it's the Achilles heel. We don't rush them out of the hospital. We've learned through registries that most of the AV block after Evoque happens in the first 7 days. So you do the procedure, everything is fine. Day 2, they want to go home. Cardiologist taking care of the patient's fine, they want to go home. You send them home with a Holter monitor, which we do routinely. Then they have, you know, 30 seconds of asystole. No good. We keep them now for at least 5 days. Gives you a bit of time to watch the rhythm, you know, adjust the diuretics. Patients may feel like, why are you doing this? But we've had patients get heart block on day 4 or day 5 and get a pacemaker. You know, our ability to predict heart block after TTVR is limited. It's not the same as for TAVI. You know, if you've got a left bundle or really slow AFib, you put in a valve on the right side. I think that makes intuitive sense, and that has been shown in registry to predict heart block. But it can be quite unpredictable and sudden, which is a bit scary.
Thank you for a wonderful talk. If I was a patient, I probably don't want to see the fluoro images of these big valves, but it's amazing how these technologies have really made a difference in the physiology and able to actually put it in there. I'm a heart failure cardiologist, and I think the space of the right side has been forgotten, as we talk in our field as RV, as a forgotten ventricle, now the forgotten tricuspid. But it's opening up the undiscovered area of venous capacitance, venous congestion in the gut with a lot of devices on acute heart failure. My question is, when you design these trials, the challenge I feel on the right side is the lag in outcomes, which are related to mortality, are limited by the resilience of the liver and the kidney. So when you're designing these studies, is there a alternative opportunity to figure out how to incorporate liver dysfunction and kidney dysfunction as an outcome? Now, it's always a difficult discussion with FDA, but If you think about it, heart failure hospitalization was never a valid outcome until the last 7 to 10 years that we added it on. So my question is there any discussions as in the trial space to figure out how to incorporate these outcomes so you see some benefit before it gets to the mortality
Yeah,
stage?
no, it's a great question. So we actually published a paper to look at all the patients who are undergoing TTVR screening. They all get CT scans, they show the liver, and about 2/3 of them had cirrhosis. Even though clinically they didn't necessarily have more than child A, they had cirrhosis on imaging. And those patients actually did worse than the ones who had no cirrhosis. So, you know, the TRISCEND-2 trial did not show a big improvement in liver or kidney function at 1 year, but they're relatively healthy patients. In real world registry data, and certainly in our population, and there was a publication from Europe, there is an improvement in liver function. Bilirubin, all these things go down, the creatinine clearance improves a bit. So as far as putting that as an outcome, I think that's probably a good thing. Whether people believe that improves their survival, I don't know, but having well-functioning organs, I think, is kind of important. You know, heart failure hospitalization for the right side can usually be managed as an outpatient, so it's harder to prove that it reduces hospitalization. I think other metrics such as like days in hospital, number of times they have to come to the ED or the clinic for IV Lasix, these types of things, you know, probably are relevant measures as well. But if you enroll patients who've had a previous heart failure hospitalization, maybe you'll see a reduction. Only about 1/3 of the patients in these trials had a previous hospitalization the year before being.
Well, thank you so much. Great talk as usual. So despite that we have, brewing data, there's always limited data and a lot of selection in the trials that have been published and ongoing. In your clinical practice, how do you determine the patient who is too far gone that you say no, and the ones that actually prehab might give them a chance to be good in TTVR and stuff like that?
It's a good question. So, I mean, for me, the biggest question is how is their RV function? And it's a fairly qualitative assessment. I was joking around with Sasha yesterday. It's like, is the RV a bag or not a bag? It's an eyeball thing, and I'm not an echocardiographer. There are ways to measure it, and some people suggest doing MRIs, that type of thing. We haven't done that. So there's the RV, and then, of course, the comorbidities and frailty, just like for any other intervention. Excuse me, prehab can definitely improve patients and make them suitable candidates, but we prehab for these types of patients are old and frail. We actually prehab them and then try and do edge-to-edge repair. You can shrink the gaps down quite significantly with forced diuresis and make them treatable only by keeping them in the hospital for at least a few days. As far as optimizing them and making them a TTVR candidate, if they're already that marginal, then I worry about RV failure after.
Hello. Oh.
No. Only as rescue therapy if they declare themselves, which usually happens right after, or two or three days later. They're sitting on the ward. They just go into this low output state. No one pays any attention. Creatinine starts going up. Milrinone, 2 days. They usually recover. We don't give milrinone to all patients. Not our practice.
Good morning. Great presentation. Andrea Quarti, I'm a cardiac surgeon. And as you said, isolated tricuspid valve surgery is becoming more and more common. And as a surgeon, I'm always scared about the result, because the mortality of isolated cardiac surgery is around 10%. And so I'm very fascinated by this. I want to ask you 3 questions. In case the patient has an AV block, do you consider epicardial leads implant, or you go through the valve and possibly causing again tricuspid regurg with a lead impingement? And I want to know if you have any valve-in-valve experience, because as it happened with the TAVI, then maybe in the future you will need to do valve-in-valve, or if you have you and your group have any experience on valve explant, surgical valve explant.
Okay, so with respect to pacemakers, we have very close collaboration with EPs. EPs are a part of this heart team as well. And if they get heart block after, then we're either giving them a leadless pacemaker like Micra through the valve, or ideally a coronary sinus lead. If they can't have either of those, we have put leads through the new valve, but echo guided, so that you're not propping one of the leaflets open. As far as valve and valve, all of these devices that I've shown you are designed to be able to put a Sapien 29 in them for valve failure. We haven't had to do that yet, but many other groups have. And as far as durability of that, no one knows because it's still very early days. But there is that option for valve failure. And we haven't talked about valve thrombosis, but like valve thrombosis is a shortcoming of all these valves. If the patient can't tolerate anticoagulation, they should not get a TTVR, and probably they need to just be on it lifelong. They almost all have AFib, but some patients don't have AFib, and those patients, they need to be anticoagulated. We just put them on DOAC, to be honest. We haven't used warfarin just because of the bleeding risk.
Dr. Pham, fantastic talk. I guess my question is, like you said, the RV function assessment is generally qualitative, but do you think in poorly coupled ventricles, where the RBP coupling is poor, which is probably a better measure of actual RV function, something like moderate to severe TR should be intervened upon, where I feel, that's where we miss out and you wait for it to become severe, where now the ventricle's too far gone?
So can you repeat the question?
I guess the question is, in a poorly coupled ventricle where the RBPA coupling is poor, should the intervention be done a little bit sooner, where you intervene in moderate to severe TR rather than wait till they really get too severe?
Yeah. Great question. And nobody knows. But, there's discussion for doing intervention for moderate MR. I'm not sure that will bear fruit. We'll see. But moderate TR, or the other patient is asymptomatic severe TR who comes in on no diuretics, whose RV is a bit dilated, RV function preserved. They have no evidence to intervene on that patient. So actually, to be honest, I view triluminate as very, very reassuring. If they are such a patient, we usually just give them some, some empagliflozin or some spironolactone and send them on their way. We don't intervene. And it's a chronic disease, so they may be fine. They just have to have close follow-up.
Well, Neil, thank you for a really great talk. I mean, the parade of devices is always fun to see. I would correct one thing: the tricuspid valve is not the forgotten valve. We know it's there. We just ignore it. We pretend it's not there, but it's not forgotten. The big downside running a lot of these screening committees on the left side is we just can't get anybody treated. Everybody's screen fails, but the right side they screen fail less. And the left side, we're now talking about eventually maybe testing this against clipping. You're talking about on the right side testing valve versus valve. Do you think on the right side you're ever going to get down to valve versus clipping?
Yeah, I'd love to see a trial of valve versus clip. I don't know we're there yet because the safety of the valves is not really quite there, but the efficacy is there. But it'll be a lot of fun to compare repair versus replacement one day transcatheter. But the endpoints will have to be, you have to think about those ones carefully.
And which company is going to fund it, the clip company or the valve company? Because they don't want to lose.
And neither one will want to lose.
Yeah.
Probably the valve company. Yeah.
Well, hey, thank you for a talk. I have a question about pulmonary hypertension. Where does it fall? Because I'm a heart failure cardiologist too. So when they send a patient for me to quote unquote such and says optimize them, and then so we have they have pulmonary hypertension. We have the RV assessment, and sometimes these patients are RV so poor that it's very hard to assess how significant the pulmonary hypertension is. So how do you have any tips, and where are you cut off? They say, okay, if it is a pulmonary hypertension, I'm not going to do any valve. That's one question. Second is, even with the valve, with the tricuspid, the clip, that there still is not like a TTVR. They're not completely getting rid of the tricuspid regurgitation, but still, I'm always worried about by increasing this afterload as an RV, how much they can tolerate. What are your cutoff and how you approach these patients?
Yeah. So the trials excluded anyone who had a PA pressure more than 70. I think if you have post-capillary pulmonary hypertension, it's usually very well tolerated, as long as the PVR is not more than 4 or 5, and that's a moving target. With optimization, you can often improve all of these numbers. So we're just mainly screening out precapillary pulmonary hypertension, right? Something that's not group 2. Those are the patients who, we get referred patients with TR and scleroderma. We just treat them with diuretics and, and vasodilators. So I think the right heart cath is very important. Not all groups actually do right heart cath, but we think it's kind of mandatory. And then the other question about aflow mismatch after clip, it has happened, but the clip is usually not so effective that you eliminate TR. To be honest, the patient who develops aflow mismatch after a clip, it's usually very transient. And, we've seen it in the lab, and by the end of the case, it recovers. We've never had anyone go on inotropes after a triclip, unless they're like really sick coming in already in that state. But that's kind of a Hail Mary situation, which we try and avoid.
Great. Thanks so much, Neil, again for the talk and for taking all the questions. Just maybe a final comment from my side. As Dr. Radin also pointed out, that patients in the trials are again very different from the real world. When you look at the TriLuminate randomized data, the 1-year mortality was 8%. When you look at the single arm, the 1-year mortality was 15%. We looked at all our TriLuminate screen failures, and the mortality was 30%. So David Adams said this at TCT that perhaps if we had not been so selective and randomized everybody, maybe we would have shown a mortality difference. So I think we have a lot to learn in this space. And maybe just a final question. Again, if you had a crystal ball, where do you see the field going? Is it going to be more repair? Is it going to be more replacement? Or is it still going to be individualized? What do you foresee in the next 5 to 10 years?
Yeah, I don't think it's going to be all or none. It'll be individualized. I have a personal bias that replacement will probably be at least 60%